Hey everyone, and welcome to This Explainer. Today we're tackling a really critical gap in medical training, which is that space between physically placing ECG leads on a patient's chest and actually diagnosing the resulting potentially life-saving rhythms. An ECG's diagnostic power depends entirely on physical accuracy right at the bedside. If the setup is wrong, well, the data's wrong. So let's strip away all the noise and build our clinical confidence from the ground up.
Okay, let's look at our structural roadmap for today. This is really going to help lower your cognitive load on the wards. We'll start with anatomical landmarks, then hit 3 and 5 lead systems, and move right into standard 12 lead placement. After that, we'll shift to the software side of things with 7 steps to rhythm analysis, and we'll wrap up by decoding tachycardia and bradycardia.
All right, part 1, anatomical landmarks.
We absolutely have to start with the physical foundation on the chest wall, because honestly, if we can't confidently locate our anatomical landmarks, the entire ECG output is already compromised. To get that perfect electrode placement, you have to know exactly where your windows into the heart are. So find the sternal angle right below the manubrium. It's not just a random bump on the chest, right? It connects directly to the second rib, which gives us a highly reliable, palpable starting point. From that second rib, you can easily march your fingers down the intercostal spaces. We're going to drop down to the 4th and 5th intercostal spaces, tracing along the midclavicular, anterior axillary, and mid-axillary lines. Locking the skeletal grid into your mind, that is the absolute secret to perfect electrode placement every single time.
Moving on to section 2, 3 and 5 lead systems.
Transitioning from basic anatomy, let's check out the simplest continuous monitoring systems we use in the hospital, basically every hour of the day. There's a really elegant progression between these two. The 3-lead system relies on exactly 3 electrodes: right arm, and left leg. And a great tip here is that to get the best monitor display for bipolar leads I, 2, and 3, we actually want to place these electrodes on the chest wall, equidistant from the heart, rather than way out on the specific limbs. Now, take a look at the 5-electrode system. It takes that same foundation and adds a right leg ground plus a central brown chest lead. This is a crucial addition because it gives us the standard bipolar leads plus a single unipolar view, all depending on where we place that brown chest lead. Now, to lock these positions into your muscle memory, and trust me, this avoids fumbling with wires while a patient is sitting there waiting, classic color-coding mnemonics are an absolute lifesaver. Think white on right for the right arm. Then use smoke over fire, meaning you put the black left arm electrode directly over the red left leg electrode. Green is the grass on the ground, right? So that goes on the right leg as our ground lead. And finally, the brown electrode sits right in the central chest.
Section 3, standard 12 lead placement.
Now we're adding the final, critical pieces to complete the standard 12-lead ECG. This is the absolute clinical benchmark for diagnosing specific ischemic areas of the heart. Precision here is literally vital. We start by anchoring V1 and V2. Remember that sternal angle we just marched down earlier? Well, we place V1 at the 4th intercostal space on the right margin of the sternum, and V2 directly across from it on the left margin. But here's the trick, and a lot of people get this wrong. Do not place V3 next. Actually, scratch that. You jump down to V4, placing it in the 5th intercostal space, right on the mid-clavicular line. Once that's set, then you simply place V3 midway between V2 and V4. Finally, you trace laterally along the exact same horizontal plane as V4, putting V5 on the anterior axillary line and V6 on the mid-axillary line. It's a very precise physical choreography.
So a super crucial point here is dispelling a really common beginner's confusion. We are not placing 12 stickers on the patient. By properly placing exactly 10 physical electrodes, 4 on the limbs and 6 on the precordium, the ECG machine basically does the math and calculates 12 distinct viewing angles of the patient's heart. These 12 leads allow us to confidently interpret specific territories. We get the inferior wall through leads 2, 3, and AVF, the lateral wall through I, AVL, V5, and V6, and the anterior wall through V1 to V4. 10 wires, 12 brilliant clinical windows.
Section 4, 7 steps to rhythm analysis.
Okay, so now that the hardware is perfectly placed on the patient, let's pivot to the software side, actually analyzing the resulting printout. On a 12-lead ECG, rhythm is usually best analyzed by looking at a 10-second recording from lead I. It really helps to follow a strict 7-step framework every single time you pick up a rhythm strip. First, evaluate the rate and pattern together. Is it fast, slow, regular, irregularly irregular? Next, look at the QRS morphology. Is it narrow or wide? Third, you want to meticulously hunt for P waves. Are they absent or present? Fourth, establish the AV relationship. Is every P wave communicating with a QRS complex, or is there some kind of dissociation happening?
Fifth, note the onset and termination. Is it abrupt, suggesting a reentrant process, or is it more gradual? And finally, observe any response to vagal maneuvers, which can actually abruptly terminate certain tachycardias. This structured, step-by-step approach is exactly what prevents us from missing subtle, hidden dysrhythmias.
Finally, Section 5, decoding tachycardia and bradycardia.
Let's put that framework into immediate clinical practice by categorizing two broad and very common clinical presentations we see all the time: fast and slow heart rates. There's a really stark clinical contrast for fast heart rates, or tachycardia, and it's based entirely on the width of the QRS. If you see a narrow complex tachycardia, the electrical origin is above the ventricles. It's sinus, atrial, or junctional in nature. Think of things like atrial fibrillation or AV nodal reentry tachycardia. But if we see a broad complex tachycardia, the origin is either ventricular or it's a supraventricular rhythm suffering from aberrant conduction, like a bundle branch block. And here is a golden rule you absolutely need to remember. We must assume any regular, broad, complex tachycardia is life-threatening ventricular tachycardia until proven otherwise. Seriously, never assume it's just hour in conduction. Always plan for the worst. Conversely, when we're dealing with a slow heart rate, bradycardia, our primary task is to simply go hunting for the P waves. If every P wave is reliably followed by a QRS complex, but the overall rate is just slow, the problem is up at the top: sinus node dysfunction. If P waves are present, but they're dropping beats and not always followed by a QRS, we're looking at AV node dysfunction, like second or third degree heart blocks. And what if there are no P waves at all? Well, that means the higher pacemakers have failed, and we're relying entirely on junctional or ventricular escape rhythms just to keep the heart beating. So, simply by tracking the P wave, we can instantly isolate the anatomical level of the disease. We've covered the skeletal anatomy, the color-coded cables, the precise 10-electrode placement, and a really rigid framework for diagnosing the resulting rhythm. So I'm going to leave you with this thought. The next time you're on the clinical wards and a patient complains of chest pain and the room suddenly gets very tense, how will you apply this exact structural foundation to confidently attach those leads and instantly decode that tracing? Because the gap between perfectly placed anatomy and life-saving clinical care, that's entirely in your hands. Thanks so much for joining me on this explainer.